Yeah, exactly. They don't care about paying you, we're paying you in swag.
You ready to get started? Always ready? All right, so we're going to do a lot of hand, specifically finger stuff today, okay? So make sure we're tracking on this. We'll finish up. I'll choke. And then we'll move on to lunch, right? And then what, farm? Exciting. All right. What test do we have tomorrow? Perfect. We love it. ID's the best. False. Ortho's the best. All right. And then this afternoon we're going to have our lab. This afternoon is going to be basically covering excuse me. I'm still trying to kick this cold. Covering all the physical exams. And then you guys are going to practice for a little bit. I was thinking today, I was like, well, this lab used to be 4 hours, right? It's a lot of physical exams, right? A lot. I tried to cover some of them during class, but if you guys decide at some point you need some extra lab time, I can try to secure the lab and we'll get more practice time in, okay? Because that's important because you're also doing ClinCore, correct? So if you get a ClinCore case and they say, have you covered this yet? Are you responsible for it? The answer is yes. So if you need more time, get with me, talk to your class leader, he'll pass me a message, and we'll make it happen. The other thing I wanted to discuss is that when it comes to test review, are you guys tracking on some day next week? Test review for my test? Someday? Sunday? Okay. So we'll talk about that. All right, so we'll get started. Any questions before we get started? You guys want to do test review on Sunday? I mean, I can use ChatGPT for that. Okay. All right. So fingertip, what? Injuries and amputations, very vague, correct? So when we talk about injuries, basically we're talking about crush injuries, lacerations, things of that nature, right? So they can involve the distal phalanx, they can involve the nail, or guess what, it can involve anything, correct? So you see a picture there of somebody who had a bad day, and then on the right-hand side there, what we try to do to kind of mitigate some of that, okay? Once you get certain types of injuries, and we'll discuss those, you know, the ability to just sew it up and move on kind of goes out the window, so then more surgical discussion has to be had. Okay, but just understand that when you're talking about fingertip injuries, you always want to consider nail bed involvement, okay? Nail bed involvement is key because if you don't address the nail bed issue and you just sew it up and move on, then you can have significant complications. So you have to inspect the fingertip or exposed bone. So if you see bone, is that an open fracture? Yes, okay? Inspect loose tissue, and I talked a little bit about it yesterday, I believe, about neurovascular status, so you want to make sure the tissue is viable, otherwise it's got to go in the bucket. Okay, I worked with a hand surgeon, his nickname was Bobby the Bucket, right? So he would just say, well, that's not salvageable, goes in the bucket, okay? So inspect the nail bed for subungual hematoma. You see a picture on the bottom right there, and you can see ecchymosis underneath the nail bed, correct? Usually the rule with ecchymosis underneath the nail bed is if it's 50% or greater, the nail has to come off. You got to get in there and look, because if you have that much bleeding, it may be a significant injury to the nail bed. Okay, we good with that? 50% or greater. Okay, and we'll talk about some exceptions to that. So always want to get AP lateral radiographs. When it comes to hand, you'll see the term PA very often. Often AP, PA are kind of interchangeable. It just depends on whether the hand is palm up or palm down on the plate when they take the x-ray. So you want to determine the extent of the injury because that's really going to guide your management, excuse me. So you can see this x-ray here, it looks like there's a lot going on, right? There's a lot in the bucket potentially, but there's also fractures, okay? So again, with hand injuries, always get x-rays, okay? Fingertip injuries, amputations, x-rays. Okay, when it comes to adverse outcomes of disease, obviously other than the obvious, okay, they can go out to get crips, right? Nobody loves that. Right, but the big thing is the nail dystrophy. Even if you do everything you can to improve the overall appearance and more importantly function. You have to counsel your patients that the nail bed deformities are going to be present. And we'll talk about that a little bit more later on as well. So when we talk about nail bed deformities, the big two are hook nail and split nail. Okay, and there's the pictures there, so there you go. Okay, hook nail is literally which number on there?
4.
4, right? So that's what you would look like. A split or deformed nail is number 3. Those are the two most common, okay? All the other stuff is kind of duh, right? A hand has a lot of nerve endings, right? So they can have residual pain. And another thing you want to counsel your patients on is even after you treat them, they can have a sensitivity to heat or cold. And that could be permanent, okay? Any questions about this slide? There's a lot there, okay? So amputation is treatment. So one with hematoma, like I talked about before, you want to either do some kind of procedure. If you're not going to take the nail bed off, in order to relieve that pressure, excuse me, you have to do a procedure to express or decompress underneath the nail bed. So that technique it's showing you there is an 18 gauge needle, okay? And basically what you do is you take the needle, sharp needle, and you just poke a hole and you let the blood flow, if you will. Okay, you evacuate the subungual hematoma. If it's old, say 24, 48 hours later, and it's not actively bleeding anymore, do you think if you do that procedure, anything's going to come out? No. Okay, so just understand that's something that if it's older and you see it, then you almost have to take the nail off if it's greater than 50%. Does that make sense? So the big thing to decide is there bone involvement or no bone involvement? So this slide kind of goes through those steps. I think you'll talk more about these kind of procedures in surgery next semester. But basically, no bone involvement, right? If you have a fingertip injury, you want to make sure that you do an irrigation and debridement. We talked a little bit about that yesterday. You want to make sure if you suture anything, are you going to close it tightly? Never, right? That's the rule. You'd be surprised, okay? Wet to dry dressings. Okay. Have you guys talked a little bit about kinds of dressings yet?
Not yet.
Yeah, okay. I'll give you your first little taste of it, I guess. But wet to dry basically means if you put a dry dressing directly on something that's bleeding, when the bleeding stops, is the dressing going to dry?
Yes.
Yes. So then when you go to pull it off, right, it's going to be a lot of pain, right? And it's going to be difficult for you, more important as a provider. So if you put a wet dressing first, right, directly onto the wound, after you do your business, then you put a dry dressing and then a big wrap over it, then you have something that's going to stay wet and it won't dry to it. Does that make sense? So do you think if you do wet to dry dressings, you have to do constant dressing changes? Yes. So again, we try to get to dry dressings, which is exactly what it sounds like, just dry dressings. Okay, but that's how we say it, as soon as possible. That way you don't have to do as many dressing changes. Okay, I know that sounds lazy, but that's it. So why would you put a splint? So if you have a soft tissue injury to a fingertip, do you think if they actively bend the fingertip, or bang it on a desk, say, that's going to hurt?
Yes.
Yeah. So you put a splint on afterwards to both immobilize and to provide soft tissue rest, okay? If you have a laceration or an open injury that involves a joint, okay, what it does too is it allows allows the wound to heal in a position that will start allowing for wound closure. Okay, then you talk about primary and secondary tension, correct? So if you put tension across your repair, obviously that's going to lead to potentially dehiscence, right? It's going to open up. We talked about dehiscence yesterday a little bit. And so you want to reduce that tension on the wound as well. All good with that? Okay, range of motion, occupational therapy. We talked about that as well. OT is kind of the elbow, hand, wrist people. Anytime there's bone involvement, what's in red? Ortho, that makes sense, right? It's literally called the bone and phone at most commands. You call the bone and phone if you have bone involvement, okay? Tetanus status and, rabies, depending. You want to check that and address appropriately. And then antibiotics for grossly contaminated wounds. We could talk all day about antibiotic indications for hand injuries. The hand people will tell you we don't use antibiotics. we're a bunch of liars, because when we go to surgery, we do use antibiotics. But there's literature that suggests that given the nature of the highly vascular hand, that you don't need antibiotics unless it's grossly contaminated. So that's your key there. Do most ERs give antibiotics?
Yes.
Okay, but as stewards of good practice, right, we have to understand that we want to mitigate antibiotic resistance. So I will tell you that the key indicator for antibiotic selection is gross contamination. Good to go? Okay. Red flags, referral decisions, younger than 6 years old. A kid lacerates their hand, you think they're going to sit still even if you numb them up? No. So a 2-year-old with a significant hand laceration, that's like a 4-hour event for me in the emergency room. Because potentially we have to put them to sleep. Maybe not all the way asleep, but what we call conscious sedation, and then do your business quickly, right? Because you want to make sure they're not under medication for too long, right? Longer than needed. So under 6, okay? Thumb is something you have to understand. Opposition is your thumb, right? So if you lose your pinky, but you have your other fingers and your thumb, you're probably fine. But thumb injuries are something you're going to look at closer if they present, okay? So any thumb injuries, definitely refer. Fingers, amputation proximal to the middle of the middle phalanx, right? So that's P2, correct? Yes?
Yes.
Okay, all right, so anything what it says there, proximal to the middle aspect of the middle phalanx, okay? Multiple finger amputations. So if you have fingers that are missing, and there's a bunch of them, you're gonna refer. I would say that if you have a digit that's missing, let's say the distal phalanx, you're gonna refer those anyways, but multiple is definitely an indication. Are we good with that? Okay, there's some pictures up there showing thumb considerations and fingertips. So it just talks about the vascular nature of it and the fact that, you have to consider the long-term implications of treatment and do the appropriate management. Good to go? Okay, so this is what we discussed between the last 2 days. When it comes to animal bites, make sure you lock down on those treatment selections. Okay, give that a close look. When it comes to near deformities, we'll talk about swan neck deformities today. So you're going to want to get those straight. Understand what's the deformity of the PIP versus the DIP, and then compare those. Carpal tunnel, you're going to live that. Okay, carpal tunnel is another neuropathy potentially, right? So what nerve's involved with that? Median nerve, right? The DQ tenosynovitis, the decorticus tenosynovitis. We'll do that physical exam today, but that Finkelstein is super important. Make sure you differentiate between true scaphoid tenosynovitis palpation versus referred pain, because your decision point, we talked about differential diagnosis, correct? And understand that DQ tenosynovitis or decorticus tenosynovitis has a lot of implications too to consider steroid injections. And we did discuss those, correct? Okay. Dupuytren's, depending on how you pronounce it. That's one of those things, we'll talk today about trigger finger. So make sure you get the differences between trigger finger and Dupuytren's, okay? Dupuytren's tends to be proximal to the distal palmar crease. It involves the palmar fascia, right? The fascia, correct? So fingertip infections and fingertip injuries and amputations, we already kind of went over that. So questions about any of those topics before we move on?
Sir.
Yes, sir.
I said no, sir.
No, sir, okay. You said yes or no, sir? Gotcha. So we'll move on with this. So we're going to talk about flexor tendon injuries. This is the one that people are like, woo, man, this is tough stuff, right? Because you're going to really look at the chart I'm about to show you. So let's lock in on that. Flexor tendon sheath infections, is that a surgical emergency? Yes. So another one to kind of lock in on. Human bites, make sure you differentiate between animals again and humans. Kiev disease, that's a kind of a weird one, right? Mallet fingers, again, that has a deformity associated with it. We'll go into it. We go more into nail bed injuries, so that's why I kind of breezed to the first one. And then we'll, again, get into trigger finger. Flexor tendon injuries, so you can have different kinds, right? Ruptures, avulsions, lacerations, both incomplete and complete. Incomplete and complete, right, when it comes to lacerations, so I just want to clarify, if there's a partial laceration, then that's a category. If there's a complete laceration, is that a rupture? Yes. Okay, so that terminology tends to throw people off a little bit. Just understand that partial is partial and complete is complete. There's no type 1, type 2, grade 3, grade 1, whatever. It's either in or it's out, okay? You'll hear me say that a lot, in or out, right? Jersey finger, so that's another one of those like buzzwords that you might see on pants. Okay, that's an FTP avulsion. What is FTP? Well, it says at the bottom there. Flexure digitorum profundus versus flexure digitorum superficialis, okay? So which one goes all the way to the distal phalanx was the profound one, right? So it's the FDP, okay? And which one goes to the middle phalanx, the polar aspect of the middle phalanx? That is the FDS, the flexure digitorum superficialis. So don't get confused between those two, okay? Make sense? Ring finger is the most common. And let me go ahead and get into this now so we can breeze through a few things later on. So your middle finger is called your long finger, right? Okay? Now take your hand and make a knife hand. Okay? Now curl your fingers slowly and make a karate hand. Right? At some point, as you're curling your fingers, don't do it so fast. As you're curling your fingers, you'll realize that your ring finger is now the long finger, or the most prominent finger. Right? If it's not, right, you're like, I struggle with that because some students do. Just do it slower. Then you'll realize, you know, if I do it like this, I can see my ring finger is more prominent now. See that? Yeah. So that's why the ring finger tends to get caught, because when people have injuries, right, it's because they're trying to curl and grasp on something. So do you think a jersey finger is because someone's reaching out to grab a jersey?
Sure.
Yes. So that's why the ring finger is the most involved. Okay? If you have alien hands, I can't help you. Okay, but that's the thought process behind that. Make sense? Okay. It occurs in patients with OA and RA. RA, as we discussed what seems like many moons ago, RA does have a risk for tendon ruptures, correct?
Yes.
Yeah, because there's erosive lesions and things like that. So RA is a consideration here too. Okay, people can have non-traumatic ruptures, right, if they have RA, rheumatoid arthritis. Okay, we're good with FDS and FTP. We're gonna need to know those distinguishing factors now. You see how when you get to this point right here, the FDS and the FTP, one kind of slips through the other, right? Mm-hmm. Right there and right there. Okay, so that again, the level of injury is going to determine what is in excuse me, and what is out. Okay, what's working and what's not working, and therefore your physical exam will kind of lead you in that direction. Good to go? Okay, so clinical symptoms. Obviously, had a history of trauma, some kind of injury. Okay, they will have limited range of motion, and that may be active range of motion. Correct? That's usually what you're going to talk about. The patient says, "I can't do this anymore. I'm unable to do it," and then you do a physical exam, and you can't get them to do it either. And associated numbness to either finger. Okay. Now we've been going through this whole thing where we talk about ulnar nerve, right, radial nerve, median nerve. You have to understand that the digital nerves innervate both the ulnar and the radial aspects of your fingers. Correct? The thumb is a little bit different. Okay. But let's focus on fingers. So you want to check sensation not only at the pulp or the distal tip, but also side to side, ulnar and radial aspects too. Good to go? You see how we're using ulnar and radial again, not medial and lateral? All right, nobody walks around like this, correct? So, all right, so this is something I cleaned up. Hopefully this makes more sense to you guys, looking at it like this, because I tried to clarify it. But you have to understand FTP, right? Flexure digitorum profundus versus flexure digitorum superficialis, which is the FDS. Which one is in and which one is out? The only thing you can do with this is learn it, okay? And because if you learn this, then it makes sense. And then also understand the level of involvement. Because if it's here, right, and here, you may have some crossover, correct? Because they kind of, one dives into the other. Make sense? So if you have number one, I try to color code it. If you're colorblind, sorry. I try to use colors that hopefully work, right? So, but if the SCS is cut and FTP, excuse me, is cut and the FDS is intact, what works? We're able to flex at the metacarpophalangeal joint, the MCP, correct? And PIP, but not the DIP. Do you see why? If this is cut right here, that's the superficialis, right? Do you think they're going to be able to flex at that distal joint, right? No, makes sense, correct? Okay. Then we would move on to 2, which is right here. There's where that crossover is, right? But the FDS is cut and the FTP is cut and the FDS is cut. So they'll be able to flex at the MCP because that's more proximal, correct? But can they flex at either the PIP or the DIP? No, because it's both. Make sense? Good to go? Okay, now this is the one that throws people off. So this zone here, right, 3, right? Zone 3 right there. That means that you have to consider if the FTP is intact, but the FDS is cut, they'll be able to flex everywhere. Why? Because that distal attachment, is it still present?
Yes.
Yes, right? So hopefully that makes a little more sense. I cleaned that up, like I said. Understand that this 3 here is only denoting that the FDS is cut, right? The FDS is cut. It does kind of suck that that picture has the FDP labeled that way, but right there is not the FDP, it's the FDS is cut. Good to go? Okay. So if you look at that line, does it transect the FDP? No, it's only the FDS. Okay? Questions about this? Pause. No questions? Nobody wants to know? Okay. You'll look at it Sunday when you do your test review on your own. Okay. So flexor tendon injuries, so you want to test active range of motion. Doesn't matter if you can move it. It's a flexor tendon. You want to see if they can flex, correct?
Yes.
Right? Thank you for answering. So you do it by isolating. You want to isolate the DIP, PIP, and MCPs, okay? And you want to make sure you isolate each finger, right? I think we talked about this before, but your small finger, right? I didn't use pinky finger, correct? So your small finger and your ring finger share common structures. Okay, so if you don't isolate the pinky finger, the small finger, then you may get some collateral movement that it comes from the ring finger, correct? So you got to isolate. And then when you isolate, it's just like it sounds, and I'll demonstrate this a little bit in lab. You want to make sure you isolate finger motion at each specific joint. Good to go? Because then you go back to this chart and you figure out what's wrong. Good to go? Okay? All right, so patients with partial lacerations have full range of motion, but the pain is going to be out of proportion. So they're able to do it, or it's a weak effort, right? But they have significant pain. Okay? I use the word pain, correct? Do you want to check this motion and neurovascular status before or after you numb somebody up? Before. Please God, if you call me on the phone, right, from my retirement home, and you tell me that you're unable to assess neurovascular status and active range of motion because you numbed them up, I'm going to be sad. Okay, so just remember that. Make sure you do your assessment before you numb the patient up. So do we hurt them a little bit? Yes. Like I said, ortho is not known for not causing pain, correct? So neurovascular status does also involve 2-point discrimination. Okay, I talked about the paperclip method. You just take the paperclip, you unroll it. It's 5 millimeters is normal, correct? So how do you determine what 5 millimeters is? So your small fingernail, okay, is approximately, for most people, again, if you have alien hands, sorry, but for most people it's about 1 centimeter. So you take that paperclip, you unroll it, right? You unwind it, if you will, and you make it so that the width side by side is half the width of your pinky finger. Good to go? So that's a gross way we're doing it, or just kind of a down and dirty way. Okay? Does that look like, it looks like here, like the patient's unable to flex at the middle finger, correct?
Yes.
It's the FU finger, right? It's just stuck in that position, okay? All right, so imaging-wise, you have to get imaging for these kind of injuries, okay? Flexor tendon injuries, because if you have an avulsion injury, that's significant, okay? You'll see that here in the slides soon, okay? So if you have avulsion injuries, the treatment is completely different, right? So is it still called a jersey finger? Yes, potentially, right? That's at FDS, like we discussed before. But If you just splint it and wait for it to heal, you'll be waiting a long time because it's not going to heal. Okay? So, wrist, why would you involve the wrist? Well, first of all, the principle is the joint above and below, correct? So if somebody has an injury, you want to assess. But you're also looking for that hook of the hamate that we discussed before, arthritic changes, again, that RA, those lesions, okay? And there it says metallic prominence. So when it comes to wrists, if people have distal radius fractures, do people have surgery for that? Yes, right? So there's a plate that people put on the volar side of the distal radius, and that plate, if it's too prominent, right, the surgeon doesn't put it in the right place, either because of technique or because of the fracture that existed, then they can rub on those flexor tendons as they glide over that plate. Make sense? So that may give you a clue as to why this patient's experiencing the symptoms they are experiencing and why they were predisposed to have a flexor tendon injury. Are we good with that? Okay. So adverse outcomes disease, pretty straightforward, loss of flexion, loss of strength, loss of sensation. Okay. So when we talk about treatment, so non-operative, I cleaned this slide up. Non-operative is partial lacerations. If you want to call it a tear, that's fine. We tend to use the word laceration though. But that's really the only indication for non-operative. Okay. So with the laceration, again, you're going to do an IND, irrigation, a superficial loose closure, correct?
Yes.
And then splint with the fingers bent, again, to take that tension off the flexor tendons. Okay, makes sense? Okay, so does OT come into play here sometimes? Yes. You have to fashion certain splints? Yes. These splints that are shown here in these pictures, these are custom splints that OT can make. Again, OT can really be helpful. I love OT. Okay? So operative, complete rupture, tear. So that's not a partial, that's complete, right? It's out. What's in, what's out, okay? And you want to get to it soon. It says within a week, but I can tell you right now, if somebody comes in with a flexor tendon rupture, right? Complete laceration, then we tend to take them as soon as possible. They come in for fracture clinic at 0730. We're in the operating room by 0900. Because will it start to retract and go up into the palm? Yes, over time it will, and then it'll start to scar down. Okay, make sense? Okay, some adverse outcomes of treatment, post-op infection. Obviously, if you have surgery, infection risk is there and present. Failure of repair. So, a lot of times we do different suture techniques to repair tendons. Analysis was one suture technique. There's a bunch of them. Okay, Krakow suturing. But even with our best efforts, sometimes the patient goes on to have a rupture. Okay. Do you think that even if we do surgery, we put them in a position like this where their fingers are flexed to take the tension off that tendon? Yes, right. But we may not do a custom splint. It'll be more like a splint that we apply in the operating room, post-operatively. Good to go? Gotta take a drink. Sorry. So we talked about zones of the finger, okay? Now you have zones of the hand, all right? So zones of the hand are something, when you call me on the phone, you should tell me what zone the injury's in, if it's not specifically obvious, okay? Or if there's multiple injuries. So when you refer them to me, right, because you're gonna refer anything as suspected flexor tendon injury, okay? Anything, all right? At least give us a call. But your book says to refer any flexor tendon injury, so I'm going to lead with that. Okay? So you describe using the zone. I added this slide here. Okay? Yes, it's busy, but this is hand. Hand is super detailed. Okay? I do want you to have a general sense of the zones. Okay? Because I think that's going to be important. You're going to have to know it eventually. So, but I'm not going to get into the weeds. Okay? Just understand where a zone begins and where a zone ends, okay? I'm not going to read all this to you. Is the thumb different?
Yes.
Yes, the thumb has 3 zones versus 5 zones, okay? And we'll talk about thumb injuries specifically, okay? So I added this slide. Hopefully this helps you. Take a look at it Sunday when you're studying. watching NFL football? Right? Any questions about flexor tendon injuries? Okay, it looks simple, right? Then you'll start reading and you'll do ChatGPT questions and you'll get them wrong. Because you have to understand where the zone of injury is and what's in and what's out. Good with that? Good with that? All right, that's a way to study it. Understand if you have an injury at the middle phalanx, right, you can have different ins and outs. If you have an injury to the proximal FDS, then you can have different in and out, depending on what level you're testing. Good to go? Okay. I'm going to move on unless somebody has a question. Flexor tendon infection. So we just talked about flexor tendon zones. But if we go on to say, okay, there's no rupture necessarily, but there's some kind of an injury, right? The tendon sheath, to the tendon sheath, excuse me. So flexor tendon infections tend to be called flexor tenosynovitis or septic tenosynovitis, right? So it doesn't look like this spot. So septic tenosynovitis, is that a surgical emergency? The word septic is in there, so yes. But the tendon sheath, again, this is a picture that shows you the sheaths, right? So this is more important to understand what sheath is involved. I'm not going to get into the nitty-gritty of all the different sheaths, but just understand that the sheaths extend from the DIP to the MCP joints. Okay, so that's a distal palmar crease where the MCP is, correct? Right, so when you're saying it's flexor tenosynovitis, okay, and if the patient has palm pain, does that mean that not only did it start in the fingers, but now it's in the palm, right? So it's ascending proximally. Is that bad?
Yeah.
Yeah, and that's what it's getting at there in red, severe finger infections, okay? And that can come from pretty benign sources, right? So pokes, you know, different injuries. Cat bites, there it is, okay? Cat bite injuries can have a risk of flexor tenosynovitis as well. Okay, remember those hypodermic needle injections, 2 of them from cat bites, right? So clinical symptoms, right? So you'll see 24 to 48 hours, they'll have severe pain. That's pretty fast, right? So they'll have varying degrees of pain, and then they'll come back the day after injury and it's more severe, okay? So important to understand, get a time and date as well of when the injury was, okay? Flexor-sided finger or thumb pain. I put that in yellow because if you call me on the phone at my retirement location and you tell me I have flexor tenosynovitis, and you describe dorsal-sided pain, I'm super confused. Okay, so understand that, and people are like, well, duh, right? I get calls like that all the time. I wish I had $1 for every time the ER called me and said they have flexor teno, and then it's dorsal-sided pain. So this is flexor-sided pain. Okay, I'm going to have to be teaching you more probably. So canable signs, okay, you have to know this. Pants will hit you on this somehow, some way, shape, or form probably, okay? But this is something you have to know. So there's 4 canable signs, okay? And they let you know that you have flexor tenosynovitis. First one is sausage digit. It's just what it sounds like. It's circumferential, so all the way around, swelling, okay? Is this sausage finger there? That looks pretty swollen, right? I almost said it. Oh, yes, so that's the first one, okay? The second one is the finger is held in a flex position. As those compartments fill up, right, meaning those sheaths, right, the finger will go into a flex position. So you'll look at it, and it's held in a flex position, okay? Is that held in a flex position? Yes. It's kind of hard to see in that picture, but you'll see another one pretty soon, okay? The next one is pain to percussion. Again, that's along the flexor tendon sheath, correct? So the palm, or the volar aspect, okay? And then pain with passive extension. So the finger was held in flexion, and then when you try to extend it, the patient either literally punches you, right? Or they look like they want to punch you. Okay, that's pretty significant. We call that exquisite tenderness. Remember that term? They use that word. When we use the word exquisite, that means it's bad, okay? Any questions about the 4 canable signs? You have to know this, guys, okay? So radiographs, well, it's soft tissue, it's flexor tendons. Why do we get radiographs? Well, because we're looking for that subcutaneous air, correct? You guys talked about that in radiology, I'm sure. Foreign body is rare, right? So but you're also trying to gauge the extent of swelling. Okay? So, some of the risks of this, if it goes untreated, obviously they'll have skin breakdown, right? Infection tends to cause destruction, so skin breakdown. And then it'll do what I said before, it'll creep. It'll start in the finger, it'll move up into the palm, and guess where it wants to go? The forearm, right? It just keeps ascending proximally. That's bad. Okay, and this is like life-threatening potentially. If they get septic, yeah, that's bad, right? So time is tissue, right? You guys heard me say that before. So we want to get to these as soon as possible. So it's important for you, when you guys are doing your assessments in phase 2, you know your conatal signs and you're like, I think I got a flexor teno, because time is tissue. The patient won't necessarily present an hour after injury, maybe they present 24 hours after injury. Okay? Non-operative, really it's for suspected but not severe. Okay? So it means that you're like, it looks like the start of flexor teno, but it's not quite held in the flex position as significant, right? So we're going to do some medical management, and that describes the medical management to you there. But you want to continue to reassess. You don't just prescribe antibiotics and say, I'll see you in a week. When do you reevaluate them? Right? So it's pretty common, pretty short interval, excuse me. And then, what are the bugs? Staph and strep, right? So if it's an animal bite, you're worried about other things, correct? Pasteurella multicida, things like that, right? So if you start IV antibiotics, so this is IV antibiotics. You start an IV, hang a bag and send a patient home. So this probably denotes that it's a little bit of inpatient management, or it's at least in the emergency room. Make sense? Okay. So once you get to a point where you feel comfortable this is trending in the right direction, what lab did I talk about that we commonly check for to see and monitor for progression and improvement? CRP is the key one, but yes, we get a white blood cell count and an ESR as well. So then you can do it. You can check for progression, okay? You're like, why do we always get this lab? You know, I had a sophomore ask me that question. I gave him the benefit of the doubt because he hadn't been through my course yet. But you guys now should be getting baseline labs. Good to go? Okay. When I explained it to him, he was like, oh, I can see the light bulb. It was great. So operative management, so purulent flexor tenosynovitis, not the other word. Use the word purulent, please. And if you don't know what that word is, see me afterwards. Right? Don't go to phase 2 using the PU something word. Okay, purulent. Okay, that means there's pus involved, correct? It's either expressing or it looks like it's pus under pressure. Is pus under pressure bad?
Yes.
Yes, always, right? That's when they yell, PA student, you got to go clean all the pus out. So, or what? Unresponsive to antibiotic treatment. So you've done your IV antibiotics, you discharge them with PO antibiotics, right? Oral antibiotics, and then they take a turn. Okay? It's in red. Is this something you got to get to pretty quick?
Yes.
Yes. Urgent surgical drainage. You see that small finger there? Does that have all 4 of the Knavel signs? I mean, you can't tap it, right? So that's fair. Round nose on it. Right, but it looks like a sausage digit. It's held in flexion, right? It looks like it's under tension. It looks like there's pus under pressure. So you would imagine that if you try to extend that finger, the patient's going to use their other hand to punch you square in the jaw, okay? And then you can imagine if you tap on it along the flexor side, then it's going to cause pain. Good to go? Okay. So outcomes of treatment, even if you do the best thing, right? The tendon sheath was involved, you can get residual scarring, and so they can have some finger stiffness despite successful treatment. Good to go? Okay. Should we break? Probably, right? Yeah. You want to break or you want to push? I heard break, I heard push. Let's break. Okay, we'll come back 5 after and we'll finish up. We talked about dog bites, cat bites, right? So then there's human bites, right? So human bites is what it sounds like. It occurs directly from a bite or indirectly when the hand strikes a tooth, aka bite. Okay? Bite. It's what it sounds like. You got in a fight and the tooth bit you. because you punch somebody in the mouth and you have an open wound, usually on which aspect of the hand? This time it's dorsal. Okay? So it is important to understand that if it's a fight bite, the hand is using a flexed position, right? Otherwise it's called a slap. Okay? So a slap is different. This is a closed fist injury. Okay? So when you have the fist closed, as you see in that picture on the bottom right there, right? So the tendon is a certain position. And then when you extend the tendon, it's in a different position, correct? So if the injury occurs with the fight bite and the hand is in a flexed position, right? So the extensor tendons are flexed, then the wound is created, correct? And the injury occurs to the tendon potentially with the hand in a closed fist position. Do you think the tendon is going to be in a different position once the hand is extended?
Yeah.
Yes. Do you ever examine a patient in the fighting position? No. You examine them with the hand in extension, correct? The answer is yes.
Yeah.
So it's important, that picture, what it's trying to note to you is the importance of understanding that depending on how you assess the patient, it's important to understand what position the hand was in at the time of injury. Are we okay with that picture? The extensor tendon is in green, correct? So when it's flexed like that, right, the fingers are flexed, the extensor tendons are in tension, right, because they're being stretched. Then when they relax and extend their fingers, then you see the green there? How the injury is more proximal now to the joint?
Yes.
Okay, more proximal to the joint there? Okay. Have I beat that to death enough? Yes? Okay. So pastoral multicida is not a thing here. Now you're talking about Eikenella cordis. Okay? So that's the one. So don't get those two confused. Associate human bites with this one and pastoral multicida with dog and cat bites. Good to go? But, underline, the most common organisms are still which ones?
Staph and strep.
Staph and strep. Skin flora, correct? Do people sometimes have nasty mouths?
Yes.
Yes. So they can be, for sure. She's absolutely sure. Okay? So it's important to understand that can it still be multi-microbial though? Polymicrobial? Excuse me? Yes. But the most common are staph and alpha hemolytic streptococci. Excuse me. All right? Are we okay with this picture?
Yes.
We'll look at it on Sunday. Okay. Or hopefully not Thursday night. That's a little late. Okay. You guys like the look on the guy's face as he's getting punched? Okay. So I'm looking for a better picture, but that one works. Okay, clinical symptoms, obviously a history of injury with or without a laceration. Okay, now again, that's usually the extensor tendon. Okay, infection is always warrant swelling, and I would add exquisite tenderness too, but purulent discharge. If you see gross pus, that's a sign that it's infected. Okay, tendon damage. Well, now instead of telling them to flex, you tell them to extend. Correct?
Yes.
Yes. Okay, and they have a lack of it. And then again, nerve injury is possible, and they can have a loss of sensation. Okay? So it is important to understand again that you assess not only the radial ulnar median, but also the ulnar and the radial aspects of each digit. Can't go to that spot and talk. Okay. So physical exam wise, all right, so the patient got into a fight, punched someone in the mouth, there's no fractures. But you missed the open wound on the dorsal aspect of their hand. So then they come back 24 hours later, and this is what you see. Does that look angry?
Yes.
Yes. So don't miss fight bites. Okay. It is important to measure and record locations of lacerations because again, it will denote potentially what digits are involved. Okay. What fingers. Assess extensor tendon function, assess sensory nerve function as well. Document swelling, erythema, purulent discharge, and rule out ascending infection. We just went through what that means, right? Okay. So as you look at that picture again, where you see the sheaths, do you think there's also compartments in the hand? Yes. So the sheaths and compartments are different. So it can indicate that you have an ascending infection. And then it says your swelling can take off on you about 2 or 3 hours. That can be variable. Okay, but again, just because there's no fractures doesn't mean that this isn't something that you need to manage a certain way. So manage appropriately. Okay. So imaging wise, again, same thing. You're going to get X-rays. You're going to rule out fractures, foreign bodies. Is it possible for someone to punch you, right? And your tooth breaks off in their hand? Mm-hmm. Yes. Okay. Or even a little piece of it. Okay, that's a foreign body, right?
Yes.
Yes. So lab-wise, I'm not going to beat that to death, but you see the where it says there serve as a baseline, right? So again, they're usually normal in the beginning, but then they come back 24 hours later, and they're not responding to your antibiotics. Okay? So it's important to get baseline labs. All right? Outcomes of disease, obviously, if it's affecting the extensor tendon, you can have tendon ruptures and or partial lacerations. Okay? Abscesses, that's a pocket of pus, correct? That's bad, right? Osteomyelitis, especially if it's long-standing. Okay, septic arthritis. Again, remember we talked about assessing for hand injuries, finger injuries, that you want to make sure there's no joint space violation, correct? So if they have a violation of the joint capsule on the dorsal aspect, then you want to know that, okay? And then septic tenosynovitis, okay? Don't really talk too much about extensor septic tenosynovitis, but just understand that once it gets into that tendon sheath, it can travel, correct? Mm-hmm. But it's still a concern. Good to go? Okay, so when we talk about treatment, non-operative, no joint or tendon involvement, and less than 8 hours from injury. So it's like a clock, right? So again, I told you guys, when a patient comes in, know time and day of the injury, right? What position their hand was in when this injury occurred. Because what they're going to tell you is, you're going to look at their hand and you're going to be like, this is a fight bite. It's pretty obvious, right? But they're going to deny it, okay? Are you going to treat it as a fight bite? Yes, 100%, okay? Now, if they have a gross bite, you can see every single molar and incisor on someone's hand because they got bit by somebody, right? So you see that in kids a lot. Kids will bite each other, right? In school, call Gene to get them, even though you don't want to. But less than 8 hours, then you're going to do what? I&D, correct? And are you going to dress it with wet to dry dressings? Yes, right? For the reason discussed before, you're going to select the appropriate antibiotics that covers for primarily anaerobics. I won't go into specifics about that, but all the common bugs, right? Recheck it in 24 hours. So again, you're not just going to start antibiotics and say, I'll see you in a week, correct? All right, so if you do suturing, right, and you do non-absorbable sutures, we'll talk about it now, do you have to take those sutures out? Yeah. So you got to send them to somebody, or you have to schedule to come back, depending on where the injury is. We'll talk more about that in surgery. But depending on where it is, there's a different timeline for removing those sutures. Make sense? Okay. You think you might want to splint them too sometimes? Yeah, for soft tissue rust, correct? And to decrease the tension on the extensor tendons. And again, check tetanus status. Tetanus. We give boosters, tetanus boosters for people all the time because they're unable to verify the tetanus status. Is tetanus bad? Yeah, it could be fatal, correct? You've seen that picture of the guy with tetani? No, so they try to scare you with that, but it's a bad thing. So, operative, established infection. So it's definitely infected. So we do a surgical debridement, and then you do an IV antibiotic. So after we do the debridement, then we put them on the floor, we monitor them. Okay, and once they meet certain criteria, it's transition to PO antibiotics, we discharge them. Good to go? So what do you want to do? You want to look at the need for amputation like we discussed before. If there's clearly an indication that the tissue is non-viable, okay, and it needs to come off, that's going to be something that's going to have to be considered, okay? But then even after you treat them and they get an infection potentially, or they have an infection and then you treat them, is there a risk that they may have a loss, further loss of viable tissue? Yes. So, you have to continue to reassess for amputation concerns. Infection with primary wound closures, that's why I keep harping on the fact that we don't do tight closures, correct? A lot of times with fight bites, especially if they're not more extensive, we just let them go. So that's called secondary attention, right? So you don't do anything, especially if it's a certain size. Okay. Antibiotic allergies, that's always a concern anytime you give a medication, is that the patient may be allergic to it. So when are you going to ascertain that they have an allergy? You just did a procedure, right? So you're going to ask them, are you allergic to any anesthetics, and do you have any drug allergies, correct? So that's when you're going to elicit that information, okay? So what are the reasons to send it to us? Well, you started treatment. I guess I have to stay here. You started treatment, and they seem to be doing okay, but then they take a turn. Okay, the labs start trending upwards. That's bad, correct? So you're going to refer. Anytime there's joint capsule violation, you got to refer. Okay, because you will think everything's okay, and then they'll come back, and they'll be worse. Okay, tendon rupture, that's a pretty duh. Okay, extensor tendon repairs, I will do those in the emergency room. Those are a little bit more common to be done at bedside. Flexor tendon, where do we do those? In the operating room, correct. And then bone involvement, osteomyelitis, so obviously if it's an ultra fracture, that's a referral. Okay? Any questions about that? Went through quickly because again, we seem to be kind of hitting the same thing over and over multiple times. So with hand bites, human bites, excuse me, you want to make sure that you assess the patient and determine whether or not only do they have fractures, but to what extent the wound concerns are. Video, okay? Conibach disease, all right, PowerPoint didn't like to put the O with the two little dots over it, all right, but that's actually how it's supposed to be written. Sometimes you'll see a plural, Conibach's disease. I don't know if he actually had it, so he doesn't own it. Okay, what's the number up there? Is 40 in there? Yeah, but 20 to 40, right? So this is one of those conditions, I will tell you, if you practice long enough, you'll probably see one, okay? But this is avascularity, or some form of disruption of blood supply to which bone?
Lunate.
Perfect. Right? I can tell you guys have covered this before. So if it goes on to collapse, because that's the progression, right? Then you can have end-stage wrist arthritis. Okay? You see the blood flow there? Where is the blood flow to the lunate redundant and extensive?
No.
No, it has a very tenuous blood supply. So going on to the next slide. So clinical symptoms, they'll kind of report this pain that's kind of this dorsal central pain, okay, and swelling. So a lot of times the swelling is intermittent. They'll report subjective weakness, so they feel that they have weakness, okay, and then they say they have an inability to grasp heavy items. Well, that's going to be your indicators just on your interview that they may have this, okay. So tenderness of the lunate, pretty slam dunk. It's important for you guys to understand what area the lunate sits in, right? So you know that that's going to be dorsal and central, and so it's going to be more ulnar than the scaphoid, correct? Yes. Okay. We're going to use our terminology here. So you're going to check grip strength. This thing is called a hand dynamometer. Okay. It's also called a JMAR, JBAR, one of those two, but that's a company. So, but basically, if you have that in your clinic, you can actually use that hand dynamometer to check grip strength from the affected side versus the unaffected side. Okay. So swelling, again, like I told you guys, swelling and limited range of motion, that tends to be later. Okay. So initially, they may just report this very vague kind of dorsal central thing. Okay, so don't let that throw you off. Are you going to get x-rays? Yes, right? So there's that term PA, and lateral to wrist, okay? And then the hand too a lot of times, right? But specifically in early, you'll see that focal increase in density. So that's that sclerosis that we discussed when we talked about osteoarthritis, okay? And then later on, you're going to see an actual collapse. Does that look like a normal lunate bone there? I don't know what a normal one looks like, you're saying. Okay? But I can tell you it's not. Okay? So it is not. That's a tiny, tiny little chiclet looking thing compared to what it's supposed to look like. Okay? So if you see that, you need to call somebody. Okay? Because that means it's early or late?
Late.
Late, right? So then, if you're referring to me, I'm going to say, hey, do you mind getting an MRI? Because then I'm going to be able to stage it. right? That's important for management, correct? The answer is yes. Okay, so that's why MRIs are super important. If there's a concern for Kienbach's, especially if it's questionable, we'll get MRIs. We get MRIs a lot for Kienbach. Foot stomp, get an MRI, okay? So CTs document the extent of lunate and carpal collapse and for surgical planning. So usually CTs are something that we'll order on the surgery side, okay? But MRIs, again, are more useful for determining whether the necrosis of the lunate is present and also what stage it's in, okay? Everybody sees this view here. Is that supposed to look black there?
No.
No, right? So that's a certain view where bone is supposed to be white. You know, highly vascular viable bone is supposed to be white, so that's an indication that that's more end stage, correct? Yes. Okay. So outcomes of disease, if you do nothing, okay, they can have proximal row osteoarthritis. Okay, that's secondary osteoarthritis, correct?
Yes.
Because a lot of times there's no history of actual trauma. So that's why this is a weird one. Patient will just come in and start describing this vague dorsal central pain. And you'll be like, yeah, well, there's no history of trauma, right? So when we talk about proximal row, what the heck is he talking about? So here in this, we talked about the different bones, right? Of the wrist, the carpal bones. Mm-hmm. Some lovers try, right? You guys remember that acronym I gave you? It's recorded. I'll just say it. Some lovers try positions that they can't handle. So this row here, right, goes all the way around to over here, right? So this is proximal row, right? And this row here is another row of bones. So this is dorsal row. Oh, excuse me, distal row. So that's what I'm talking about with proximal row. Okay. So do you think, so since it's proximal row, will they have decreased wrist flexion extension potentially with end-stage disease?
Yes.
Okay, so then we need to move on here and say, okay, so they have secondary OA. Okay, so non-operative management. So this is when you catch it early. Okay, so you look at it and either you suspect it, but the radiographs are actually normal. Okay, or they have significant sclerosis of lunate, but you're like, okay, you get the MRI and it's not end-stage disease. It's not more significant disease. We won't talk about the different stages. Come see me in fellowship if you want to go and get into that, okay? But you're going to try splinting in the neutral position for 3 weeks and monitor them for improvement. If you lock them down on a splint, should their pain increase or decrease?
Decrease.
Decrease, correct? Stiffness will set in, but not necessarily pain, okay? So that's important. We'll talk about it here in a second. NSAIDs for pain management. Yes, I know you guys probably have read that study that's in laboratory mice. It shows that NSAIDs actually decrease bone healing. Fine. Okay, again, that's a discussion that we can have, but NSAIDs tend to be used. It's just the proper selection. Okay? So persistent pain after 3 weeks equals refer. Okay, so that means that they're not improving. You see them, and even though they're splinted or neutral position, their situation is not improving. So if you haven't already gotten an MRI, do you think I'm going to ask you to get one?
Yes.
Yes. Okay. So operative, that's when you talk about that proximal row collapse, right? Because this is a bony collapse. So therefore, they have secondary osteoarthritis. So then we have to do things not only to manage the disease process itself, but also to manage the patient's expected pain. Correct? So can we do certain procedures like an arthrodesis? Right? So that's where you fuse a joint, right? We can do that. But if we fuse that proximal row, do you think the patient's going to have less or more flexion extension? Less. So that's a discussion. Good to go? That's your surgical discussion. Okay, my surgical discussion. That's what I just wanted to kind of let you guys know. So adverse outcomes of treatment. This is even if you catch it and treat it, they can have loss of motion. We just described that. Chronic pain. Can they go in and have crips? Right? Decreased grip strength, that hand dynamometer, I love that word. You can use that to monitor the improvement of that. And then there's always NSAID risks, right? Gastric, renal, etc. So when are you going to refer? I will tell you this. If you look at that x-ray, if you get an x-ray, excuse me, you look at it and you see that chiclet-sized lunate, you need to refer that, right? So I would say that in most cases of Kienbach, suspected Kienbach or confirmed Kienbach, you're going to refer. Okay? Make sense? So all abnormal lunate findings. All, okay? Persistent dorsal wrist pain despite 3 weeks of mobilization. We went through that earlier. Yes, sir.
So, let's say 3 weeks is the last, and I've had a moving position.
Yes.
Put in my ortho referral.
Mhm.
Let's say 2 months out, I went out for this. Do we continue to do the clinic at that point, or do we decide to focus on like those different?
So what he's saying is that you do your splinting for 3 weeks in the neutral position, correct? And then I will tell you this. His question was, what do you do if they continue to have pain, a couple months after? If you call me and tell me that story, do you think I'm going to take that patient from you? Yeah, probably. Okay? Now, if I send them back to you and you have a concern because they come back 2 months later, and despite the treatment that I've provided, okay, you're concerned that the pain is taken off on you, okay? Then you're gonna call me. Make sense? You guys need to get real comfortable. I don't want to get on soapbox because we're trying to finish up. But you need to get real comfortable with getting uncomfortable. Okay? I know people are bad and tough in the communities they come from, potentially, right? But you will learn when you guys get out there that there are some specialties you don't want to call because they're mean. That's okay. You need to get real comfortable with calling those people. Do you think you're going to call them more often when you guys start practicing? Yes. You need to have a relationship. Yes, sir.
I don't think you might answer this question, but it's more, what do we do in the interim between
Nothing.
the end of the 3 weeks and before they receive
That's
the remove the splint?
Okay, good question. Was that your question? Okay, so I'm sorry. Thank you for clarifying, and sorry. So what his question was, you see him in 3 weeks, you refer him to me, okay? And then what do you keep the patient in? Do you keep him in a splint? The answer is yes. Okay, keep him in a splint, keep him immobilized. Can you make it worse if you have a lot of motion in that joint and a lot of tension across the flexor and extensor tendons? Yes. Did I answer your question now? Now, the one time I don't ask, did I answer your question? Then I didn't ask the question. Okay? Yeah, but seriously though, when it comes to getting comfortable with referrals, because this is the thing, right? Am I going to see them right away? No, not necessarily, right? This is something. But if you have a concern, pick up the phone, please. Okay? If you're having an issue with somebody out there, especially if they're an ortho PA, text me, let me know. I'll give them a call. But hey, man, you need to be more accessible. Okay? Because there's a reason we go to fellowship, correct? So when you go out there in the big, wide world of Army and Air Force, Navy, right? There's no coach season here, right? But you're dealing with the Coast Guard. Make sure you have a relationship with the ortho PA, your command. Okay? Because it'll make your life easier. Good to go? So when it comes to Kienbach's disease, it's very vague, right? So what are they normally going to test you on PANCE? They're going to test you on your ability to understand early versus late findings. Okay, and then your appropriate management. Okay, if it's a late thing, or you have a significant concern, are you going to refer them? Yes, that's it. Mallet finger. All right, so mallet fingers, by definition, a mallet finger is that an extension or a flexor side injury? Okay, all right, so you guys are putting them in compartments, right? You're figuring things out, right? So a mallet finger, all right, so that is that extensor tendon at the most distal insertion, okay? So with the mallet finger, a lot of times, again, it tends to be which finger? Ring finger. Okay, middle finger, ring finger. Okay, so, but it's not the same as a jersey finger, and it's not the same as a boutonniere. Okay, so it's an inability to straighten the finger at the DIP joint. So you have the patient put their hands palm down, right, and they're unable to extend at the DIP. Correct? Because it's the extensor tendon where it inserts at the most distal aspects. Okay, so you see how on that top picture there, that's what we call purely ligamentous. So meaning that that it's just purely pure tendon there. So that's a tendon rupture. Okay, so that involves the tendon itself. But can you also have in that bottom picture, it shows you that a piece of bone that pulls off? Yes. So do you think the treatment for those can be different? Absolutely 100%. Okay, bless you. So, but the thing about it is the patient will be unable to straighten the finger at the DIP joint. So obviously, if we're unable to straighten the finger of the DIP joint, let's talk about this real quick. Do you think that the patient's going to present in a position with the DIP joint in a flexed position passively?
Yes.
Yes, okay, that's what you're going to see. Okay, and if it goes on long enough, you can have what's called swanning. Okay, and we'll talk about that here in a second. But that's a compensatory change of hyperextension in the PIP. Let's go ahead and knock this out. So do you have flexion or extension in the PIP joint for boutonniere? Flexion is the answer. Yes. Okay, but this one says hyperextension, correct? So this is not a boutonniere. Good to go? So that's that position you're going to find them in. They're literally going to walk in and be like, ooh, that looks weird. Okay, and they're unable to do anything about it when you test them. Isolated testing of the DIP will reveal they cannot extend. Okay? But you can take it and passively extend it. Okay? Do you think if it presents a month out, you might not be able to passively extend it?
Yes.
Yes, it may be more difficult. Okay, but on acute injuries, the patient will be unable to actively extend the DIP, but you'll be able to do it passively. Okay? So usually they'll have pain acutely, but then as it goes on to progress, they won't actually have that much pain. Okay? So avulsion fractures is the reason you're going to get x-rays. So you get those x-rays and you look at them and you see that avulsed piece of bone there, and you're like, ah, this is a mallet finger. Yes, but this is what's called a bony mallet finger. It involves an avulsion injury. Okay? So if that bone is pulled off there and the extensor tendon is no longer doing the extensor component of it, are the flexor tendons intact?
Yes.
Yes. Okay? So therefore you have a pull of the flexor tendon. So the distal phalanx, the P3, the distal phalanx, can actually be pulled in a volar direction. Does that kind of make sense to everybody? So you may find it in that position. Now I know it's hard to see there, okay? But I can tell you there's a little bit of volar displacement there, okay? Because again, the flexor tendon is intact. So if it's purely the tendon, it's going to look like this, correct? Right? There's no bony component to it. Okay, so those are two different presentations you may see on X-rays. Good to go? Any questions? Okay. So if you don't do anything about it, especially if the patient presents late and you're not able to do much about it, right? Short of surgery, then they can have extensor lag. So that the extensor lag literally means that they're going to be stuck in a position where they're in a flexed position and you won't be able to extend it past a certain point. Make sense? Okay, even after successful treatment, you can have upwards of 10 to 15 degrees of extensor lag when they're still not able to fully extend, but that's considered successful treatment unless the patient doesn't like it. Okay? Well, where's that swan neck deformity? There it explains it. Okay? And this again has to do with the flexor tendon pulls. Okay, so when you talk about swan neck deformity or swanning, right, you have hyperextension at the PIP and flexion at the DIP. So remember that finger was flexed at the DIP before, right? So now it's going to heal in that position, but the compensatory change will be that they'll also get a hyperextension of the PIP joint. Good to go? So treatment, you need to know this. You're going to see mallet fingers. Okay? So treatment is continuous splinting, 6 to 8 weeks. Right? So that means they wear it all the time. Correct? All the time. Never take it off. Not even, like they can take it off for hygiene, and you teach the patient to keep their fingertip on a wall and keep the finger in extension. Okay? As they're switching it out. Okay? So that's continuous splinting for 6 to 8 weeks. So if somebody comes to see me, right, especially Marines, right, and I tell them, I say, this is going to be splinting for 6 to 8 weeks, I tell them, if you have the finger, right, so it's a ring finger normally, and you take it off, the splint off, and it goes into flexion, 6 to 8 weeks, right? Then you put the splint back on, and you take it off the next day, and it goes into flexion, 6 to 8 weeks. I just keep saying 6 to 8 weeks over again, and flexing, extending, flexing, extending. And you're like, wait, so my treatment might take forever? Yes, because every time you flex, you're taking away any healing that has occurred. Does that make sense? Because you are flexing down, and you're breaking up any healing that happened on the extensor down, the side, excuse me. Make sense? So that's continuous. That's the key word there. So you see them back in 6 to 8 weeks, you assess them, and then you transition to splinting for 2 to 4 weeks. I think that's pretty fast, but that's what your book says. Okay, 6 to 8 weeks, continuous, then night splinting for 2 to 4 weeks. Make sense? Sorry about that. Operative, so if the patient has a job, your book uses cooking, dishwashing, and typing. Clearly this book was written for civilians, right? But say they do something that requires a lot of fine manipulation, right? So if it's the patient's right hand dominant and they're an infantryman, do you think that mallet finger might cause an accidental discharge?
Yes.
Potentially, right? They may just do it anyways, but I'm just saying that there's just certain concerns that we'll see in the military, and that's when you're like, okay, we may want to consider surgery for that, or if it's chronic, okay? But definitely for avulsion injuries, correct? Yes. Okay, so adverse outcomes of treatment, there you see a couple different splints. Okay, I like to use these splints here. Okay, I think those are really easy to use, and you can flip them. So this is an extensor injury, right? Extensor side injury. Can you flip it and use it for flexor side injuries? Yes, you can. All right, so which joint's involved?
Distal.
Distal, PIP. So do you need to immobilize the PIP? No. Right, so these splints are really nice for achieving that. This is what you see in the E-arm, right? A lot of times they're put on there wrong. Right, this one over here on the left. And the Coban wrap is too tight and causes skin breakdown. It's just, if you have the stack splints or the figure 8 splints in your clinics, use those. Okay, good to go? So, red flags, distal phalanx volar subluxation. So that's usually found in those avulsion type injuries, correct? And there it says, avulsion injury, what's the amount of the articular surface that needs to be involved normally? 1/3, is that what the slide says? So if they have 1/3 of the joint surface or more involved, you're going to call us. So how do you figure that part out? Okay, so you look at that looks like over 50%, right? The joint surface they're talking about is the most proximal aspect, right? So the cup, if you will, of the distal phalanx. Make sense? Any questions about that? I know I'm using a lot of terminology. But does that look like more or less than 50%? It looks like a little bit more than 50%, right? So is that greater than 1/3?
Yes.
Okay. I don't like to do math in public, but my math comes out the same. Okay, so you're going to refer those. And then if you see that swanning, that last one's talking about swanning, you're going to refer those too, right? So if you see swanning, do you think you want to split them?
Yes.
Or immobilize them to get back to that point earlier until they're seen by me? Yes, because you want to stop that progression. Make sense? A lot of times you see that as well for incomplete or patient non-compliance in treatment. But there's still a nail bed injury, correct? And it affects the germinal matrix. So that's why I was trying to give you guys a pointer. If you see significant subungual hematoma, that means that that nail matrix is probably violated. That's the term we use. It's not being funny. Okay? So you see that fingernail there? Does it look like potentially that it involves a nail matrix or germinal matrix? Yeah. Highly suspicious, correct? That's not that deformity. That's literally the trauma. It's not the split nail that I was mentioning earlier, is what I'm saying. So pain and obvious deformity, it's important to determine the extent, assess for subungual hematoma and to what extent you think it's present, and then an avulsion or laceration of the nail. So an avulsion is pretty straightforward. The nail's hanging off a lot of times, right? But the laceration, again, could not be obvious. You suspect it based on the level of subungual hematoma present, and oh, guess what? You got an X-ray, and you see a fracture of that distal phalanx. Is that what that's showing you there? Yes. So what's the distal phalanx fracture called sometimes? Tops, right? So that's just the tip fracture. Okay. So a lot of times, if you manage that appropriately, non-operatively, does that avoid the operating room?
Yes.
Very common thing. Okay. Especially if it's just a tip. Okay. So, but nail bed and injury, and a fracture equals open fracture, which equals a phone call referral, correct? Physto injuries in peds, there is one condition that I'll get to here in a second that's a pediatric concern. Parents may ask you about it. Okay, we'll talk about that here soon. Okay, but you see the big white arrow, you can see the fracture, right? So this is why it's important to get x-rays. If you see a fracture like that, and you see a greater than 50% subungual hematoma, do you think that nail's coming off?
Yes.
Yes. Preferably before the hematoma dries up, like a leg bed. Okay? There's that picture again. I just wanted to present it again. So if the germinal matrix is violated, you can have those permanent nail deformities. The two most common being hook nail and split nail. All right, not testable, just important to understand. Like, what do I tell my patient? All right, that's what you tell your patient. You tell them they could have nail deformity, and the two most common of those. Okay. So subungual hematoma, there's a better picture, I think, of that decompression. Okay, so you want to decompress. Is that greater than 50% up there?
Yes.
Yeah, it's pretty straightforward, right? 50%. All right, pretty significant. So, so you want to decompress that, right? Because I don't relieve pain. So if you have a cauterizing pen, right? Everybody knows what a cauterizing pen is. It's a heated tip pen. You can use that as well. Just be careful when you do that. If you're doing that, don't go too far, because then you just cause the internal matrix injury. You just want to heat up the nail bed, correct? So irrigation and debridement, I added explore the nail bed. It is important to understand that just because you go in there and clean, washing, look in there, see if there's anything in there, right? See what's going on, and if you see the bone fragments, you're going to call me, right? So repair laceration. So here's a teaching point and a learning point. Do not use non-absorbable sutures to do your nail bed repair whenever possible. Okay? Is this a procedure you're going to have to numb the patient up and stare at them for a while and do it?
Yeah.
Yes. So when you go to take those sutures out, you might have to numb them up again, right? So if you can just knock it out right off the bat and complete your treatment, that's better. Make sense? The other thing is with the non-absorbable sutures, there's less tissue trauma if you use the correct ones. Okay? Have you guys talked about suture selection at all yet? No? Very brief? Okay, I won't get too far into that. I will be involved next semester with you guys in surgery training as well when it comes to suturing. So we'll get into it more there. Okay? Yes, sir. That's a good question. Yeah, so we'll talk. So this is just literally talking about the nail bed laceration, correct? So that's actually a laceration to. His question was, is this talking about the nail bed versus the nail, suturing the nail down? Okay, yeah. I just want to make sure before I get in trouble again. Yeah. So this is talking specifically about the nail bed itself. The nail is off, correct? So you are performing a repair of the nail bed, right? To make sure that you're addressing that nail bed matrix. Right? That way they have less of a chance of them growing an abnormal nail or not growing a nail at all. Make sense? Did I answer your question? Okay, good. So finally, right? So then you, after you do all that, you want to dress it and splint it. Do you think that you put them into a little splint to allow for soft tissue rest? Yes, right? And then wet to dry, dry to dry, et cetera, et cetera. So now we'll transition to nail avulsion. So that means either the nail's hanging off and you complete the avulsion itself, or you took the nail off, okay? I provided this picture here to show you. This is one technique of doing it. I don't necessarily do it this way, but basically, if you're gonna suture that nail down, okay, after you've done your business, all right, do you think it's smart to use absorbable suture? I think it is, okay? Whenever possible, because if you need that nail on there, does that provide protection for the nail matrix? Yes, just that distal aspect of the phalanx itself, right? There's a fracture underneath, correct? Potentially, okay? So that provides protection there. So if you put it back into place and allow for the nail to hopefully continue to grow like normal, do you think over time that both the suture will absorb and the nail would push off that old nail? Yes, right? So that's one way to say, well, I'm going to do this and forget about it. But a lot of times what ends up happening is people just kind of shove the nail under there. They think it's going to stay there. It's not staying on there, right? Unless you put suture. And then when they take a dressing off and the dressing's dry to the nail, it just comes right off, right? So really it's about protecting the nail bed. Good to go? Again, you guys are going to learn to that next semester. Okay? We good? You like the yellow arrows I put there to make sure you don't confuse the pictures? Yeah, I gotta make them Marine Corps proof. So I have a Marine in the next class, so I have to be careful. So nail deformities, obviously, you're gonna counsel your patients. If you don't remember the two most common ones, that's fine. You just understand that they're gonna ask you, okay? All right, so here is the pediatric one, okay? So that's that yellow physo injury. We'll come back to the other referral decisions, red flags. But this is called a Seymour fracture. This here is a normal open growth plate, okay? Right there and right there. I can tell you that that's the long finger and this is the ring finger, just because I know, okay? Or it's the ring finger or the small finger, but anyways, the point is, if you have an open growth plate, do you think if tissue breaks off because of a nail injury and gets shoved into that open growth plate, that it can cause an arrest of normal growth?
Yes.
100%. That's called a Seymour fracture. Okay? So what you'll see a lot of times when you go to assess kids are always getting their fingers stuck in doors, right? Right? So it's just like this phenomenon, right? They just can't open doors. Or they shut the door in their hand, right? So what you'll see is the proximal nail fold, you'll see the injury there, okay? So that's how that tissue gets shoved into that physis, okay? So especially if you have a proximal nail fold, nail bed injury, you need to suspect this, but hopefully you can go with me on this one. Does this look like it doesn't look stretched out, but this looks like it's wider, right? From distal to proximal, or if you get a lateral, the other way. Okay, it looks like abnormal, right? So you're comparing the growth plates when you're looking at these x-rays of kids. If it looks like it's stretched out like that, right, so widened, that's the more appropriate term, and you see that proximal nail fold injury, you need to be suspicious for a Seymour fracture. Good to go? Is that a referral? Of course, it's on the slide. Okay, so it is a referral. Seymour fractures are can't miss fractures. You cannot miss them. Okay? If you have a concern, you're working in the ER for some reason, you want to send it to me, that's fine. I think that's appropriate. Okay? Any open fractures and complex nail bed injuries. So what does that complex means? You look at it and you're like, I don't know. I don't know what goes to what. I don't know how to appropriately manage this. Or complex can also mean there's multiple injuries, right? Not only do you have a nail bed injury, but like we talked about before, you have a laceration. It's on or around the nail bed itself, right? So you're dealing with multiple factors, okay? So refer those patients. I'll be happy to take a look at them. You keep saying me, it won't be me. So trigger finger, all right, so trigger finger, that's distal to the distal palmar crease, or right at the distal palmar crease, right? Because that's that A1 pulley that we talked about. So this involves the flexor tendon or the A1 pulley thickening, okay? So you can have one or the other, or both, okay? Everybody see that red little ball there? Okay, that's a nodule, guys, right? That's what they're talking about. So as if there's a hard nodule like that, as it slides underneath that sling, right, that A1 pulley, if it gets big enough, big and swollen enough, right, do you think it'll be difficult to travel from proximal to distal and vice versa? Yes. So that's what's going to happen. The patient will flex down, right, the tendon will be in a certain position, that nodule will be in a certain position, and then when they try to extend, they cannot do it because it's stuck at that A1 pulley. Make sense? And by the way, you can have thickening of the tendon itself, right? So that's what triggering is. When you go and you try to extend it, right? They can't do it, but you take your hand and you extend, then all of a sudden you see it trigger, pop. Right? So it's not normal glide of the tendon itself. Does that make sense? Decent job at explaining triggering. Which fingers are most commonly involved? Long and ring fingers. What's in yellow there as far as comorbidities? Diabetes. You guys hate diabetes by now, right? You're like, I never would have come to IPAP if I knew I had to learn about diabetes. Okay? But there's a high prevalence of people that have concomitant carpal tunnel and the Corrigan tenosynovitis. Right? Does those tend to involve tendons as well?
Yes.
Inflammatory conditions? Yeah. So again, if you have diabetic, you need to ask them their history. Do you have a history of other inflammatory tendon issues? And usually they'll say yes. And they'll say, oh, my sciatica. Right? So clinical symptoms, pain, blocking, catching. Okay? All right, they'll feel that subjective. A lot of times people when they sleep, do they sleep with not bilateral knife hands? No, it's in some form of flexion, right? So So overnight, they'll kind of lock, and in the morning, they'll be like, I can't extend my finger. Okay? But as the day progresses, sometimes that inflammation improves, especially if they take Motrin, right? Or some kind of anti-inflammatory, and then they're able to actually extend it again. Okay? So painful nodule in the distal palm. I think that's maybe a little working against me there, but basically it's the distal, right? Not the proximal. So that rule still applies. Okay? Make sense? It's just that the flexor tendon may be thickened too. Is that correct? Yes. Okay. So you see that picture there? Which finger is the one that's locked? I agree, it's the long finger. Okay, so it's this one here. Okay. I think this is the female. Okay, but I don't judge. So when you look at that finger there and you say, okay, it's stuck in that position, okay, then you go to extend and they have pain in that pop, right? You unlock it essentially. Then that's when it's talking about that palpable mobile nodule that may lock finger when patient flexes and extends. It can get stuck on either side, correct? But once it gets into the flex position, the more difficult position is to extend. Right? So that's the one that's going to be potentially more painful. Good to go? Okay, so obviously if it's stuck in a flex position, can you get a contracture? Yes, right? So, and then they can also have stiffness and extension. Okay? So how do we treat these? So a lot of times with trigger fingers, I'll just cut to the chase. We will do 1, maybe 2 injections to try to decrease the inflammation. Yeah, it does provide pain relief too, great. But it's really about the inflammation, correct? Yes. And then we'll put them in a splint, all right, to allow for soft tissue rest, and then we get them moving as soon as possible. If we do splinting, normally it's like right after the injection, maybe like a day or 2, maybe 3 days, okay? But motion is lotion, right? Stiffness is the enemy, right? So once that inflammation starts to go in the downward direction to improve, then you want to get them moving, correct? And are you injecting into the tendon or into the sheath? The sheath, the love of God, the sheath, please. Right? Because is there a risk for rupture if you inject into the tendon?
Yes.
Yes, and that's also the reason why you don't do more than 1, maybe 2, right? Because then the risk goes up, it's exponential. Okay, but say you do your 2 injections, you do it on non-operative treatment, and they fail, then you send them to me. We'll do an eval, okay? And or there's no improvement after the 2nd injection. Okay, don't just keep injecting and hoping for the best. Good to go? Okay, so what do we do? A surgical release. We'll literally make an incision, go down, track it, splice, or dissect, I should say, that A1 pulley, release it, okay, and then we'll do that. We'll take an instrument, and we'll actually pull on the flexor tendon like that, and just make sure it's freely moving and there's no triggering. Okay, everybody sees that? It's pretty cool, actually. So again, I'm not going to go through this again, but there are risks with tendon injections. Okay, and in diabetics, is there a potential for the injection to cause a spike in the blood glucose?
Yes.
They don't need any more help at being non-compliant, right? So referral decisions, non-operative treatment failure, obviously contracture in the PIP joint and or a locked finger. And if they have RA, are they at more risk for this as well?
Yes.
It was in that list, right? So if you do an injection and it doesn't provide any relief whatsoever, doesn't improve, don't just keep injecting RA patients either. Well, they get 1 and done. Okay, so I'll add that. So it says single injection, correct? RA patients can be difficult. Okay? So that is trigger finger. We covered every topic from block 2. Right? Everything. I think satisfactorily, despite some of y'all's concomitant narco sleeping, we have gotten successfully through everything. Okay? I will tell you, if I look at this list here, right, flexor tendons, both ruptures, partial lacerations, I would know that chart for FTP, FDS, what's cut, what's in, what's out. Okay? That's going to serve you well in practice. When you call me on the phone, I'm going to ask you that question. Keep saying me, but when you call somebody on the phone, right, that has more hair than me because they're younger, and you say things, you're going to say, okay, stop. What's in, what's out? What's their neurovascular status? So that's important for you guys to know. Okay? Klein-Bach disease, that's a weird one, right? You're usually going to get advanced imaging for that of some kind.
Right.
Yes, so understand what an indication is for that, okay? Mallet finger, is that different than a boutonniere or a jersey finger?
Yes.
So I'm giving you some hints as to, or a way forward, if you will, at how to start studying these different injury patterns that we discussed, okay? Nail bed injuries, beat that to death, move forward. All right, so trigger finger, again, trigger finger, know the difference between trigger finger and deputrans. Good to go? Okay, I'm done. Any questions? All right, we're gonna meet for lab at what time? 1500, okay. So for now, we're gonna be up here. I'll adjust my